So then I will share a screen, Linda.
Okay.
If I do share, though, yours will go away.
That's fine. Well, I think there.
So we'll wait a minute. We'll wait a minute.
You have to wait a minute. Yeah. I'm not in charge of this. So.
I hate it when that happens.
I'm pinch hitting here.
Great.
Good.
I will say you have the greatest jackets.
Oh, thank you. No, well, there's nothing to say to that.
Somebody can't connect to the barcode.
Okay. There's something in the chat already. All one if you, it says all set if you want to share your screen.
Okay, good.
Let's go.
Do it. Okay, give me 1 second. So I get the right one. Not that one, hang on.
Well, good morning. I'm Linda Freed, and I have the honor of welcoming you today to a fabulous IPE session. I know it will be fabulous because I know the speaker. And to welcome you to join Terry Fulmer speaking about age-friendly care and public health, a framework for interprofessional collaboration to achieve equitable outcomes for older adults. I first want to start by introducing Dr. Fulmer before she leaps into her slides. Dr. Fulmer is president of the John A. Hartford Foundation in New York City. This is a critically important national philanthropy dedicated to improving the care and health outcomes of older adults. She serves as the chief strategist for the foundation, and her vision for better care of older adults is catalyzing a visionary age-friendly health system social movement. Dr. Fulmer is an elected member of the National Academy of Medicine and recently served on the Independent Coronavirus Commission for Safety and Quality in Nursing Homes. She has previously served as Dean of Health Sciences at Northeastern University and founding Dean of the New York University College of Nursing. Prior to that, she was here at Columbia at the School of Nursing, where she held the Anna C. Maxwell Chair in Nursing. Dr. Fulmer is nationally and internationally recognized as a leading expert in geriatrics and is also known for conceptualization and development of the National NICHE program and research on the topic of elder abuse and neglect. She's the first nurse to have served on the board of the American Geriatric Society and also the first nurse to have served as president of the Gerontological Society of America, which awarded her the 2019 Donald P. Kent Award for exemplifying the highest standards for professional leadership in the field of aging. There's nobody better to have up with us today for this IPE event. Terry, welcome, and over to you.
Thank you, Linda. And I'll do a sound check. Is my sound okay?
It's great.
Okay, wonderful. I thought a lot about presenting today and being with all of you, and it's always the most challenging audience are student audiences, because you just want to make sure that you leave them with something that they can hold on to and remember and care about. So I will try to do that with you, but you are in an exceptional program at Columbia with one of the most world-class deans going. And so it's an honor to join you today. I'm going to talk for about 5-10 minutes about our age-friendly health system, social movement. And we like to think of our age-friendly work as care given by anybody who's giving that care wherever you are, whether you're in an intensive care unit or whether you're in a homeless shelter. We're talking about age-friendly care. And so those are the main points I will be talking about today. So Kedar Mate is the president and CEO of the Institute for Healthcare Improvement. And our foundation, the John A. Hartford Foundation here in New York City, has its mission to improve the care of older adults. And so as I became president in 2015 of this foundation, the trustees said to me, they really wanted me to take the whole enterprise upstream to care, because we had been working on centers of excellence in geriatrics, which was really important to generate the leadership for the field and feel good about that work. But in this moment, it's like, how do we spread and scale the models of care we know, the best practices we know, the science we know? So I turned to IHI, an implementation science powerhouse, Don Berwick, dear friend and colleague, and I was on the board of IHI and knew the talent in place. So this is some of the updates from their work. And I think that, we always start by telling you there's a lot of old people, but the important thing about this slide is thinking about complexity and thinking about disproportionate harm. Older people have higher rates of healthcare utilization, and they experience higher rates of delay, discoordination, and harm. We can't do that. That's not a good use of anybody's resources, and it creates suffering. So we know that we have the evidence, but it's not reliably applied. We know wonderful ways to improve care for older adults, but a very small proportion of people in this country actually have their care needs met reliably through these models of care. So we are out to change that. When we began our work, we took a look at the evidence-based practice models, and we looked at 17 care models, including like Niche and ACE and Boost, and an array of programs that exist in the literature, and found that there were 90 care features that we could find in that pre-work. They were redundant. We got it down to 13 in a room in August in 2016 with a group of experts and CEOs. And then we agreed that we could all live with the vital few, the 4 M's. And I'd like to talk about that for a minute before Linda and I have a conversation. So here's our 4 M's for an age-friendly health system, an age-friendly care, and an age-friendly ecosystem, which is deeply connected to public health. When you think about the vital few, the 4 M's, every single time you address the care needs or health needs of older people, you start with what matters to them and knowing and aligning with their care preferences and what their goals and cares are across the care setting. This is a set. You don't pull it apart and do one at a time. You address it collectively. And the next M is medications. And that is if a medication is necessary, and if somebody is using a medication, make sure that it doesn't interfere with what matters to them, their mobility or their mentation across the care setting. Their mentation, mood, memory is something that we really want to identify early in order to make sure that we identify, treat, and manage things like delirium, depression, dementia, and any other thing that would cause mood disorders in older people. And then mobility, ensuring that the older person moves safely every day in order to maintain function. That's public health, and do what matters. So what matters, mentation, medication, mobility, they are fluid. If one goes wrong, they all go wrong usually. And so we see this as an on-ramp to thinking about best practices in care for older adults. And yesterday I was on a call with the Hospital Association of New York State, where all these health systems were reporting out on what they were doing around the 4 M's. And they are now much more sophisticated than I am about this work. It's really very impressive. So we've done prototype testing in health systems. And when I say systems, these systems also have nursing homes. They also have community-based clinics. Many of them are with federally qualified health programs as well. And so we've taken it quite far with this work. So in the first phase, we did a lot of implementation guides, and many of these, to be fair, they speak to primary care and acute care. In this next phase, we're really working on the entire continuum system of care, but all of these materials are free on the IHI website because they've been funded by the generosity of our trustees at this foundation. We also have, I think it'll show up in a minute, we also have book that we wrote on age-friendly health systems, because some of us don't like to mess around on websites all the time, and we'd rather pick up a book and go front to back. So in this next phase, we're really working on spread and scale. And so we're currently in 2,900 settings of care, including 100% of every CVS Minute Clinic in this country, which is kind of great. CVS joined right in, and they saw the wisdom of it, and we're working with the other convenience clinics because it gives them a reliable way to address the care needs of older people. So we have people who are participating, people who have gone the next step, sent us data on committing to care excellence. And let me just say that this number always makes me smile because it says more than 1 million older adults have been reached, but we know it's exponentially higher than that. So we've been working on nursing homes, and what we want to do is really get Linda and I to talk about all the ways that public health is central in this work. And I'd like to just share a few points about our age-friendly public health system work before I go to conversation with Linda. And here are some of the things that I think are so important for you to know. We began our age-friendly public health system work in 2017 when we funded Trust for America's Health in Washington, D.C. under the then leadership of John Arbach, who I understand will be a professor for you this week, and worked with Megan Wolf and John to figure out the crosswalk between age-friendly health systems and age-friendly public health systems. John and I have known each other a long time, and it always makes me laugh because when we initially started our conversations, we were doing what's known in the literature as parallel play. I would talk about better care for older adults, and John would talk about the principles of public health, prevention, promotion. And he would say, you know, cessation of cigarette smoking. And I'd say, function, John, function. And we started laughing and hit it. We hit it when we began our work on the 6C framework of age-friendly public health. We have a national recognition program, champions who are working with us, and we funded the state of Florida right off the bat for obvious demographic reasons to get going on age-friendly public health offices. And I must say that of the 67 counties in Florida, over 65% of them signed on, and now we're in all but like 2 counties. So that's really great. So we're excited about that work. We know that we have 16 publications already, 37 conference presentations. There are monthly blogs and seminars on the TIFA Wellness and Prevention Digest. And we have an age-friendly public health system newsletter with 900 prescribers. So Linda, that's a update for you as well, because we hadn't talked about that. And a beautiful 6C framework, which is advancing health equity through healthy aging and age-friendly public health. So the last point to say is that we're now working intensively with the following states: Florida, Mississippi, Washington, Michigan, and Georgia. They apply to work with us. And we have the following states who are doing activities and will be online: New York, Alaska, Hawaii, California, Colorado, Kansas, Illinois, Indiana, Wisconsin, Minnesota, Tennessee, Maryland, West Virginia, Maine, Idaho, Vermont, Virginia, Puerto Rico. So we're pretty pleased about that. 22 states already since 2017. And so, but we need every one of you to know the story so that you can tell it for us and make it better. Let me turn it over to you, Linda, now.
Thank you. This is a great intro. So maybe this is IPE Day, and we have online from every health profession school at Columbia. Really fabulous. And I'd like to, you and I are both geriatricians. We both have spent a lot of our lives in clinical care and also on the population health side.
Yes.
I'd like to start by asking you, Terry, what drew you to geriatrics and why have you stayed?
Thanks, Linda. I began my career at the Beth Israel Hospital in Boston, a Harvard teaching hospital, on a general medical unit. And as within the first few weeks, what was clear to me was the following. I could have complete autonomy as a nurse at Harvard Medical School by leading with what I knew best, which was better care for older adults. Here's a couple of examples. If an older person had a pressure ulcer in those days, it was in the 70s, and I said, to the intern or resident, my patient has pressure ulcer, what do you want me to do? They'd say, do whatever you usually do. Don't ask me. I don't know. Incontinence, confusion, falls. They just said, that's, do what you want to do. And I thought, oh, this is great, actually. So we began our niche program, started our geriatric efforts around improving care for older adults in the hospital. And it was just wonderful. And life is timing. One of your faculty, Jack Rose, started the Harvard Division on Aging about a year later, and I was right there and jumped on the opportunity to join that faculty, work with that interdisciplinary team. And I find it so gratifying because I know what I lead with and how I make an impact and how I improve the care of people during that hospitalization, but also after they go home.
So you started out by saying that the gap, the huge gap between the care we currently provide and the care we know matters is of great concern. That we can make the evidence is that we can make a huge difference in providing the care that matters. What difference do you want to make?
I will feel really gratified when people say to me, I'm an age-friendly health system, or when my relatives say, let's make sure we go to Bassett Medical Center because they deliver age-friendly care. When I hear the public say, I demand age-friendly care and I deserve age-friendly care in all the settings, then that's when I will feel the lift, if you will. And we're getting there.
Yeah. So one of the astounding gaps that you and I both know is that, as you said, a quarter of patients who we care for are older. The US will shortly have 20% of its population be older. We know a huge amount about both the pleasures and the content of delivering care to the dominant population that needs medical care in the adult population. And yet very few people are trained with expertise in geriatrics. What do we need to do to solve that? Because this is the future.
My solution to that is to make sure that every care provider understands approaches to age-friendly care and that they then call on experts in geriatrics when they need them. But you and I both know that if you can get people talking about what matters, mentation, medication, mobility, reliably using evidence-based scientific measures like the Get Up and Go test, for example, or like whatever cognitive screen you want to use in a reliable way where you see in your run charts better patient outcomes, better human outcomes, then that's what we need to do. I have stopped talking about the paucity of geriatricians. It's not interesting and people's eyes glaze over when we talk about it. So, and I know that that's anathema to say, but I do believe that. I think we have to just reframe it, Linda, like you have done so beautifully. You talk about the third age dividend and the fact that older adults are the only growing resource on the planet. That's you. And I love that reframing. And I would say every single one of us has a responsibility to provide age-friendly care at every point of care and to teach family caregivers about age-friendly care. We've done runs on NBC News, WebMD, Next Avenue. All of those are public-facing audiences, and we're finding that makes a difference. And we've also had people test us. They go into CVS Minute clinics and say, tell me about age-friendly, and people tell them about age-friendly. Then you start to see things change. Everybody has to do it.
So you're addressing many critical issues and how to solve the huge gap between need and opportunity. And, I would say that one of the other things which we talk a lot about is the need to set aside anachronistic myths which have been disproven about who we are as we get older. Mm-hmm. Everybody now has the opportunity, really, for longer lives. Astounding change from 100 years ago in this country when life expectancy at birth was 47. We've practically doubled that because of our investments in health, as well as education and poverty alleviation. And now the challenge is hugely how to provide the care that we need that helps people recover and do well as they can in old age and oldest age, and how to keep people healthy as long as their life expectancy.
Right.
Now, one of the things you and I both know about what makes geriatrics and care of older patients so fabulous is that this is a team-based proposition. This is a team sport because of, as you were saying, the complexity of health issues that arise as people get older and the necessity for every person who's on this call to have a role in that. So I'd like to talk about teams. So,
Great.
and something you and I both have had lots of experience with and care about a lot and know deeply matter. So tell us about your early experiences with teams in care of older adults and why you became convinced that that's what we need for the future.
Sure. I'll give you two examples. When I was at the Beth Israel, the state of Massachusetts passed a mandatory reporting law for elder abuse. And Mitch Rabkin and Joyce Clifford, who were the CEOs of that organization, asked me, they knew of my interest in aging, and they asked if I would create a response to the state law that would be appropriate for our setting. So we started the Beth Israel Elder Abuse Team, and it was an interdisciplinary team. We had medicine, we had people like Ken Meinecker, people like, you know, all the names, I'm going to lay, you know, Lou Lipsitz. And we had our social work team, we had our nursing team, and we had other therapies with us as required. We met every Wednesday from 12 to 1 for the 7 years I was there. And they continued to this day. It was an interdisciplinary team. And what we learned in that moment was sometimes you didn't need a nurse. Sometimes you don't need a doctor. Sometimes you don't need a social worker. So getting the right people in the right place at the right time and feeling confidence in your teammates to hand it off when they have it. And that's a really strong feeling. So I had that experience. We wrote a lot about it. It was part of the fellowship program at the Harvard Division on Aging. And I was very proud of that. Jack Rowe used to tease and say, you know, this is the only team I know that meets every single week and never asked me for a penny, which was true. So fast forward, I was at New York University, and I was on a lot of teams in between then, you know, and certainly at Columbia, working with Barry Gerland and the wonderful people in the various colleges at the, you know, the health science campus. And we worked on the North Manhattan Aging Project together. And that was a research-based team project where we went out in teams to interview older adults, river to river. I know you all know the NMAP program, and work with people like Rafi Lantigua, who was working on diversity in aging and team-based care. So that was a great learning. And then when I got to NYU, we had the wonderful opportunity to be funded by the John A. Hartford Foundation to set up a program called GIT, Geriatric Interdisciplinary Team Training. There's a book about it. There's a book about everything I'm talking about, because I make sure I write a book about everything we do. Because if you don't have lots of different ways for people to learn things, you don't leave a legacy. So that GIT book, the lead author was Jeannie Siegler, is one where the foundation invested $11 million on geriatric interdisciplinary team training before the internet. So that means we couldn't Zoom, we couldn't do a lot of things creatively, but what we did was a lot of science. And one of the probably most powerful scientists in the team was Bob Kane. You want to tell your group who Bob Kane is?
Well, Bob Kane was, because he passed away recently, an eminent geriatrician who really was a national leader for many, many decades in nursing home care and long-term care.
So we had a set, Chris Castle was in that group. We had a very strong and powerful group of people working on geriatric interdisciplinary team training. And we had one component of that work where we did quantitative study on what is the problem? What is the question you're trying to answer? Who needs to answer it? And in that, we learned that we again proved with evidence that you don't always need a physician. You do not. And so what am I talking about? I'm talking about the dose of team. Sometimes when I'm invited to go to places, I'll go into a room and there's 12 people sitting there and they say, this is our team. And I'm like, great. And I'm counting up dollars and FTEs and number of minutes and saying, think carefully about the way you deploy your teams, but do work in teams and do feel confidence in your team members when you know they're the right people to handle the question at the time. So the Get book, there's a lot of papers we wrote about it. And then the next project that I worked on around teams was funded by the Josiah Macy Foundation. And that was called NYU 3T. It was teaching, teaming, and technology. Mark Triola, who is still at NYU, wonderful, wonderful physician, led that with Maya Jukic, who's now at UT Austin, a nurse professor. And they did have the internet. So they created videos and ways of measuring. And that was another exciting opportunity for us to work and measure teams in training at the interdisciplinary NYU campus. So I have a lot of experience in this, and I know that we have to have team-based care to do our job well, and we have to be scientific about it and have the quantitative measures to say how to do it.
Thank you. This is great. So I'll just echo from my own experience starting in the late 80s. I also led geriatric teams. And what I learned, and I think this exactly matches what you said, is that as people get older, the multiplicity of health problems that can confront them is such that things can get pretty complex. And you need teams that can disentangle the complexity of needs and find the most elegant and simple and straightforward solutions.
Yes.
And so with that goal in mind, I wonder if you could talk about, sometimes people look like a team, but they're actually a group of people doing parallel play. What can you talk about from your experience? What makes a team, what defines an effective team, and why do sometimes teams not work or even fall apart?
Yeah, you have to understand the mission of your team and have everybody agree that that's your mission. That's where it can sometimes fall apart. You have to have regular goals so that you can know whether you're meeting them or not. You have to have cohesion, and two other things are really important: trust, and I'm going to say loyalty to one another, and to obviously to the people you're serving. That's the most important thing, to your organization. So all those things come together, and when people don't like each other on a team, it's pretty clear. And when that happens, you need to stop and address it and say, this isn't working. So we had one stint in our elder abuse team where we weren't getting along. And Terry Weddle, another icon in public health, previously Dean of Brown Public Health, and was with us at the Harvard Division on Aging. She forced us to do a 10-minute debrief after every team meeting to ask what was going on. It's very helpful, and we got through it. So sometimes you have to do those, what I'll call inconvenient exercises that most of us, if you're a physician, you hate it. And if you're a nurse, you also hate it. If you're a social worker, you're more likely to like it because you're going to be, it is your sweet spot, and our social workers led the way.
So very, very important. Now, you've referred to needing triple aim teams. What do you mean by that, and how do we do that?
Sure. The triple aim is a phenomena that was first described by Don Berwick and colleagues when they were thinking about what to do with the report Crossing the Quality Chasm that came out in the 80s, I believe it was, and thinking about how we would get to quality and safety for older adults in their care, for everybody in their care. But the triple aim is better care, better health, lower costs. Better health, better care, lower costs, right? So what that means is not more care. And right now in the United States, we have a fee-for-service mess going on, along with some bundled payments and some value-based organizations. And in the middle of it all, it is a little chaotic, to say the least. We spend $3 trillion a year in care and healthcare in this country. And whenever I'm on a WHO call, I am humbled by where we are on that chart, which is usually very far toward the bottom. So I think that everybody wants value. Everybody wants quality. We don't want unnecessary care. Right now we're in this whole conversation about how much screening is too much screening. And I think that that's where public health really has a huge role to play. And
Yeah.
we're sorting that out.
Yeah. So I'd like to go back to something you just raised about teams.
Yeah.
And how they work on the ground. And perhaps we're talking about clinical teams right now, but we also might expand that to clinical and public health.
Community teams, sure.
Political, public health, and social work. But you raise the issue of trust, and trust is pretty critical, along with sharing the same mission. Trust includes trusting that people. It's like a chamber orchestra, right? So in a chamber orchestra, all of the members of that team count on each one knowing how to tune their violin or cello or whatever the instrument is, how to play it expertly. That was their job before they got to the team, is to know everything about how to do it well. But then you add, and people trust until disproven that has been.
That's right.
Right? But then there are other elements of trust that have to be built between team members. What do you think those elements are?
I want to underscore your point about we expect people to come in proficient.
Mm-hmm.
And when you make an observation that in your opinion, someone's not proficient, you have responsibility to name it and to be helpful in the solution.
Mm-hmm.
Helpful in the solution, name it. One of the things that worries me is sometimes I'm a nurse, sometimes I'll be in practice and I see people avoid naming things. Like what? You just contaminated the field. Come on, people, name it. And then say, how will we, time outs in surgery? What we've learned is time out. Is this the right limb? Is this the right patient? Is this the right? We have to do more of that. And we do it in the community as well. Is this the right goal of care? So I'm from upstate New York and I have a cabin in the Adirondacks and the closest hospital is an hour and 15 minutes away. And the first healthcare person to arrive is the fireman. And that's the way it is. And I trust them because they've got a lot of experience. That's the community. There used to be public health nurses, but they got gutted out of this, they're not there anymore. They're just Herkimer County. So I think that'll come back and it has to come back. But in the meantime, you've got your EMTs and your first responders is the fire truck. So I trust them because they're proficient and I see it and I can name that. So I think we all have to participate in that continuous quality improvement, PDSA, name it, help solve what you're seeing. And I hope that answers your question about the way I think about it.
Now, there's another dimension of what you just said, which I'd like to pull out as well, which is that there's an element that different members of the team need to be proficient in understanding what the other members bring to the table.
Right.
That's really a requirement of an effective team.
It is, and that takes communication and time spent together. The labels in teaming is forming, norming, storming, performing. That's the adage. So forming, you come together. Storming, you argue about things. Norming, you norm about exactly what you just said, Linda. You know, what do you know? What do I know? What can I trust you to do? Performing, and then checking your performance around what you want to accomplish.
Right. So if you think about the fact that we need each other to provide the optimal care and caring for people, to enact that effectively, we have to understand what the other is responsible for, what their proficiencies are, and when they should be at the table instead of us or with us.
Right.
Are we with them?
And let's talk about family, and let's talk about the person receiving the care as the driver, the conductor of the orchestra. So that's where you get back to what matters. And I think you said that we have some public with us today. And so these are people who could be educating us right now about their experience of care, whether they felt like they had control or even if they had a say. And it's hard for us to ask that because we're not always sure we're going to get the answer we hoped for. But until we get to a point where we do the post with people and say, okay, we just finished your visit today. We just finished your community health visit, or we just finished, this visit in your home. Did you get what you hoped for? Was this what you expected? What do we need to do next? And usually we're looking at our watch and backing out the door as that's going on. So we have to be better listeners.
So your point is critically important, that in the context of clinical care, our mission is the best possible care and health outcomes for the individual we're caring for. And the patient in this context is at the least a team member and optimally a team leader.
Yes.
So let's think about different kinds of teams. So if you're talking about, if we move from the individual patient to populations who we also care for, because both in the aggregate, the sum of optimizing individual care is a healthier population. But much, as you were saying about age-friendly public health systems, much of population health has to be delivered at the population level, where in fact the patient is the community and the whole population.
Right.
And then we have, as you well know, I have come to think of this as we have two sides of the health coin. We have clinical care and we have public health leading the creation of population health and healthy longevity. In that context, let's talk about the teams. How does clinical care defer to, and when should clinical care defer to public health? And when should public health refer to clinical care?
Sure. Nobody can experience that better than you as a physician and public health leader. Remember that we're in academic health centers where we have our community of scholars to work with. This is not the case in a lot of places in this country. I'm on the board of Bassett Medical Center. We're 6,000 square miles of what I call rural poverty. I'm not kidding, upstate New York. And so it's a whole different lens for the way I think about care. The other group I think about is Hudson Headwaters. Have you ever heard of Hudson Headwaters? Okay, so they span in New York State. Think about the St. Lawrence River. They come across the St. Lawrence River and down the Northway, about to Saratoga. And there's this wonderful guy, Tucker Slingerland, who's a physician, who has cobbled together the health of the North Country. It's magic to watch him because he knows who in the community is ready and willing and appropriate to create the care scenario that is needed by the people in that region. Bassett, similarly, and different than certainly Columbia. So I think that we have to name our public in order to, who is our community and what is it that we're trying to accomplish, number one, and do they share that, so your family and community councils, as they're called, are critical. We use them all the time upstate, and we use them downstate, of course. But to have that family council say, no, that wasn't it. You don't get it. This isn't what we need, is humbling and instructive. So I think it's getting the voice of the public with you, naming your public. And the other thing that makes me smile is that sometimes we name our population, but we didn't really let them know. And at the same time, other groups are naming the exact same population, and we're doubling efforts in the same place. That doesn't make sense to me. And I think all the scholars who are about to graduate from your program will figure that out for us.
So just as we were saying that the team leader for a clinical care team is the patient, the team leader for a population health approach is the community.
Yes.
So let's think about the headline of your age-friendly health systems movement.
Mm-hmm.
A health system includes many components, includes clinical care, includes clinical care in many settings, the hospital, the outpatient setting, the home. It also includes population-delivered public health.
Right.
That's part of an age-friendly health system or any health system. It includes many components, all of which are essential and add up to an age-friendly health system. And that word is not owned by any one component
Correct.
of the health system. And you have made that point elegantly in your title of age-friendly health system. So let's work that example for a couple minutes, if it's
Sure.
okay, on three different issues. Let's talk about first pandemics. What's the role of clinical geriatrics? What's the role of age-friendly public health in a pandemic? We happen to have lived through one of them for the last couple of years.
Yeah.
Each have roles that are totally critical, and where things have failed, we have not optimized the strength of both parts of that.
Yeah. I told you at the beginning of the call before we went live that I've lost my smile over the past 2 years. And I was watching, for the audience, I was watching videos of myself, and it was terrible because I looked like the biggest grouch in the world, but I feel grouchy, by the way. I'm disappointed. And, we just had Katrina very recently, and here we go again. Here we go again. Every time there's a public health crisis, it's because we weren't prepared. I am all about shoring up the public health system in this country. I know the Commonwealth Fund is doubling down on that, which I applaud them for. And we're right there to watch and see where we'll fit in. I think that, let's talk about nursing homes, all right? What kind of systemness do we have in this country where when the pandemic hit Metro New York and the East Coast, all PPE went straight to the ICUs, all personnel, equipment, meaning ventilators, all masks, gloves, and gowns went to the ICUs. If you were in a nursing home in this city, in these boroughs, you had none of it. None of it. You were using garbage bags and maybe whatever somebody sewed you a mask. And that's 2020 in the United States of America. Are you kidding me? I know from stories that they were locking up the PPE if they had any, because they're afraid the staff were going to take it. Why? Because they were afraid that they were going to contaminate their families and their patients. What kind of systemness is that? And is that going to happen again, Linda? I told you also that April 6th, tomorrow, is the release of the National Academies of Science, Engineering, and Medicine report on quality and safety in nursing homes in this country. And everybody can log on for free. And I beg you to do that because it's instructive no matter where you give care or how you give care, because it hits all the elements that cannot happen again. And please watch it. The last time a report of this nature was done was 35 years ago. Guess who chaired that report? Sid Katz. Who else was on that? Bruce Vladeck, Barry Gerland, Columbia, right? And I talked to Barry recently and I said, please sign on, Barry. And Bruce is going to sign on because I want them, what they're going to say is, we told you that 35 years ago. So are we serious as a nation? Will we eradicate ageism in our lifetime? And this is where people, I bet you're sick of hearing me because I feel like I'm lecturing, and I am. I want you all to worry about this with me. There's a wonderful IHI saying, and it goes, never worry alone. I want you all to worry with me, please. I'm worried. I'm very worried. And one of my solutions, I think I'll end with this, Linda, because I'm going long, is to say, I think that if every person who fractured their hip and went to the hospital for care stayed at the hospital until they went to their house, we'd solve these problems pretty fast. It's only payment that keeps them going to a skilled nursing facility. And so we have 1.3 million people in nursing homes in this country. We probably have that many empty beds. Why don't we just close all nursing homes and just put all of our resources in the place where everybody has the resources already? That's not going to happen in my lifetime, but I think we have to think dramatically.
So on all of these issues you're raising, which are absolutely critical for us to learn from and to fix.
Yes.
But the point you're making is that we have to be, all of us, every single person on this webinar, have to be a team together to get the system right.
Yes.
To defer not just to one's own needs at the moment in a pandemic, to make sure that the continuum of needs are addressed right, so that we're not stealing from each other to be because of the blinders we have about what we only are doing.
Yes.
We can look at the big picture about the population's needs. And I can't help coming in and saying we need medicine and social work and physical therapy and occupational therapy to be as strong advocates for doing what you said, which is to reinvest in the public health system we need, because the US, what we saw in the pandemic was the consequences of 60 years of divestiture from the mission of public health, which is to keep all of us healthy and create 70% of a population's health. We have to be pitching for each other to have a team for a health system that will matter for everybody. So let me go to some different dimensions of that, because what you're trying to do in the age-friendly health systems movement is to make age-friendly health systems an essential pillar of the health system. All components of it, not an add-on, not a minority vote, not good if you have time, but a central pillar of a health system that's good for everybody. Can you explain why?
Sure. First, I'd like to just address why we used the phrase age-friendly health systems. That's because in 2006, and I'll show you a slide in a minute, the World Health Organization named age-friendly cities. Alex Kalachi, John Beard, age-friendly cities. People understand it. There are measures and metrics for it. I'm on board. The next AARP was the US base for age-friendly communities. Very good, 2012. So we need to stay consistent. Don't confuse the public. Age-friendly cities, age-friendly health systems, age-friendly public health systems, so that they can understand what we are talking about and that they see a continuum and that they can follow the narrative with us. It's annoying for us to keep changing lenses instead of working together. I didn't make up age-friendly, it was made up already. And I welcome it because I think that it's great. And what we've done, and I'm going to show you a slide in just, well, a screen in just a second, is work with the Age Friendly Institute in Boston, that's Tim Driver and Jody Hsu, to create an age-friendly ecosystem conversation. We had 3 wildly intense meetings where we teed up each of those communities, age-friendly cities, age-friendly health systems, age-friendly public health systems. We brought in public health leaders, yourself included. We brought in government officials. We brought in WHO and the UN. And we said, okay, we want an age-friendly ecosystem. Can you work on that with us? And they did. And if you go to, I'm going to show you the screen. If I can, here it is. Yeah. Okay. So this is the Age-Friendly Institute. And if you go to this site and you hit initiatives, it'll say age-friendly. And then at the bottom, it says age-friendly ecosystem. And right now it's a little awkward to get exactly to the right screen, but like 2 clicks later, you get to this compendium that has 6 constructs that everybody in those calls agreed work, no matter what you're talking about, age-friendly universities, age-friendly workplaces, age-friendly public health systems. So I recommend that to you. And what we also want you to do is be highly critical of this work so that we can improve it. So this is the Age-Friendly Institute. Our foundation funds the Age-Friendly Institute. We fund age-friendly public health. We funded the National Academy of Science, Engineering, and Medicine report on improving the quality of care for nursing homes. And we are not going to let up until we see this happen. So I'll take my screen down.
So Terry, thank you. I can't resist adding that one dimension of age-friendly, which the public health system in particular has the responsibility to accomplish, given that population-based approaches are responsible for 70% of a population's health, is that to accomplish healthy longevity, to enable people to arrive at old age healthy and stay healthy, we have to resolve health disparities. We have to. That is the key to healthy longevity. That's the key to everyone having the opportunity for not just longer lives, but longer lives with health. And so a life course approach to prevention at a population level, we have to invest in by investing in public health. And that is part of the age-friendly continuum, is assuring people have the equitable opportunity to be healthy in old age.
Well said. I would also like to underscore the Robert Wood Johnson work on a culture of health. You know, Risa's a geriatrician, but she set up a culture of health, starts at birth, and they will be completely focused on that work, and they're making a difference. We salute them.
Yeah, totally agree. So I'd like to add one last question, two last questions, and then we have a few minutes for questions from the audience.
Sure.
That. One question from the audience is, can you say again the name of the National Academy of Science, Engineering, and Medicine report that's coming out tomorrow?
Yep. What I'm going to do is pull up a screen so that it's exactly right. I've got a copy of it behind me, but this is easier to show you. Okay. Here we go. I just have to find the screen. Here it is. Okay. The National Imperative to Improve Nursing Home Quality is the title. And here's the screen. I think you can all see it. Am I right, Linda?
Yes.
April 6th. All you do is just Google the National Imperative to Improve Nursing Home April 6th. Plug yourself in. Please join. This is sponsored by the Health and Medicine Division and the Board of Healthcare Services at the National Academies of Science, Engineering, and Medicine. And I cannot tell you how grateful I am that they did this work. And let me say that I had been talking to staff at the Academy before the pandemic saying, you know, it's been 30 years, we need to do this, we need to do this. And they have a long list of people like me saying we have to do this. But when the pandemic hit, I called Victor Zhao and I said, "You've got to be kidding me." And so to his credit, on we went. He said to me, "You'll like this." And he said to me, "Are you calling me slow?" I said, "I'm calling you slow." So he got right on it, and I'm grateful to have it, and so that we can get the work done. We've also made grants to the Brookings and to Leading Age, which is the national organization for long-term services and supports under Katie Smith Sloan. And we funded the academies as well as frameworks in Washington, D.C., Reframing Aging. They just completed a study called Reframing Nursing Homes. And all of those groups are ready to take the recommendations, there are 7, and move them into policy. So your good work as Columbia writ large to get this accomplished is so important to us. So that's that screen.
Thank you for that.
Sure.
So you have been a master of spreading good ideas, and I'd like to end by first thanking you on something and then asking your thoughts for all of us about how every one of the people on this webinar can help spread the good ideas that you have been putting forth today. I just want to thank you because the Hartford Foundation has also been a key leader with the National Academy of Medicine in envisioning and creating the National Academy of Medicine's new report to be released in May, a global roadmap for how we need to create healthy longevity. So everyone should look for that. I've had the honor of co-chairing that commission report, but it's really due to leaders like Dr. Fulmer saying this was critical. And it leads me into the last question, Terry, which is how do we all join together to spread all the good ideas that you have put forward and work as a team on that?
Yeah. Find your passion, be wildly persistent. All of you should read the book Getting to Yes. I think it's in its like 12th edition. Uri and Fisher, Getting to Yes. They also wrote a book called Getting Past No. They made a whole thing of it. But when there's a moment where no is not an option. It's just not an option. We're going to have age-friendly health systems, and that's the way it is. And so find your passion, be willing to negotiate, collaborate, give a little, stand your ground. So give a little, stand your ground, do both, and have fun with it. You know, Linda and I would say, I can speak for her. We've had fun and we're having fun. Have fun with it. And find people who can make you laugh. There you go.
Fabulous. Well, I think the time has gotten away from us, and it's actually time to conclude. This has been just the greatest fun to talk with you, Terry. Always an honor.
And for me,
you're for all that you do, all of your leadership and your vision, and for making a profound difference for all of us and for the world. Thank you so much.
It's a great pleasure. Have a great day, everybody.
Take good care, everyone. Thank you for joining us. Bye-bye.